And with that, I'll turn things over to Nick. He can introduce himself and we'll get going.
Hey, good evening, everyone. Or I think it's evening for everyone. Might be very late evening for some folks. So my name's Nick Hume. You guys know me. I've helped host a few of these sessions before. I've taught one or two of them. I'm a BCEHS paramedic. I'm a primary care paramedic in Victoria, BC. I'm a St. John Ambulance member with Division 176 here. Technically, I'm attached as a provincial staff officer, but I do most of my work with 176. I've been a scuba diver since 1995, very much in an on-off capacity, and I want to be very clear. It has been a few years since I was in the water, but I have been, diving really for a couple of decades of my life. I am, or previously was, a qualified PADI dive master, a DSAT trimix diver, a TDI rebreather diver, closed circuit rebreather diver. I did my training as a remote area EMT dive medic with the Diving Diseases Research Center out of Plymouth. I actually trained in Thailand with them at Queen Sirikit Naval Hospital in Bangkok. I've lost track. I'm a terrible person at logging my dives, but I've got many hundreds of dives logged as deep as 245 feet on trimix in both warm and cold water in North America, Asia, and Australia over the last 25 years or so. None of that's intended to brag at all, but I'd like you guys to have a sense that I do not just deal with this in a clinical capacity, but I do also practically apply a lot of this knowledge as a diver, have in the past. So tonight we're going to talk about dive emergencies. I'm going to assume that everyone in the audience has basically zero knowledge of diving and go from there. So if you are a diver, if you have a bit of experience with hyperbaric medicine, the first bit of this is going to be review. There is a very steep learning curve to all of this. We're gonna have to learn a lot of physics before we can get into the clinical medicine, because you need to understand the hyperbaric physics before we can get to the medical stuff. So we're going to start from scratch. We're going to build everything up really fast. At the end of our sort of physics lecture, there will be an opportunity to ask questions to clarify any of the science, chemistry, physics that we've been talking about before we move into sort of a clinical medicine realm. So, dive emergencies. What is scuba diving? That's what we're going to talk about first. We're going to talk about how it affects the body. We're going to talk about gas exchange. We're going to talk about tissue perfusion. We're going to talk about what can go wrong, and we're going to talk about what we can do about things when they do go wrong. So, first up, what is scuba diving and how does it affect the body? So, for those of you who can see this slide, it should be more, I guess. There's a picture of a diver. One of our members here in Victoria is quite an active diver, so a lot of these were contributed. A lot of these images were contributed by his dive club as well. So SCUBA stands for self-contained underwater breathing apparatus. The really short version of things is that divers use gear like this, and you'll see this diver has a tank on his back. He's wearing a full face mask with a regulator, two regulators actually, one that steps his oxygen or his air content, from his tank down to a sort of a medium pressure, and then a lower pressure regulator to help him breathe that. This guy's wearing a dry suit, carrying some fins. Looks like he has a helmet mounted light. Might be a video camera, I actually can't tell from this photo. And a whole bunch of other stuff. We're not going to go really gear heavy on this, but diving is a very gear intensive sport. So divers use gear like this to go to places like this. Typical recreational diving has limits in depending on how you define it, 60, 100, or 130 foot range. We'll go with 130 foot definition today, or 40 meters. But your typical recreational diver does not go down below about 40 meters or so. Technical divers go a lot deeper. The reasons for going scuba diving are myriad, literally everything from sightseeing to science to research. Most recreational divers enjoy just going for a dive and enjoying seeing the wildlife and the scenery and all that. There is a big difference between cold water and warm water diving. Again, things we're not going to get into too much tonight. A lot of the images you're going to see are from cold water diving. So if you're a recreational diver who's just sort of been going on resort dives, when you've been on vacation in the Caribbean or somewhere else warm, you might see some unfamiliar gear here as well. So having said all of that, surprise, physics. I kind of warned you guys about this already. We're going to have to spend probably 20 or 30 minutes reviewing some basic atmospheric and gas physics to be able to understand what's going on with the medicine. There will be an opportunity to ask questions for clarification at the end of all this. So first off, atmospheric composition. What is our atmosphere made of? We all breathe air every day. We're all hopefully breathing air right now. What is our air actually made of? Well, our air is made of really 2 or 3 sort of primary components. About 78% nitrogen. This is really important. Remember that it's about almost 4/5 of the gas you're breathing in right now is nitrogen, right? 21% oxygen, so about 1/5-ish of the atmosphere that you're breathing in, or the gas you're breathing in and out right now is oxygen. When you exhale, incidentally, you only use about 4% of that oxygen. You end up exhaling about 17%. Just how mouth-to-mouth resuscitation and assisted ventilations work. And then finally, those of you who are astute mathematicians will have noticed that 21 and 78 add up to 99. The last 1% is like 0.9% argon and a whole bunch of other trace gases. We're not really going to talk about those. We don't care about those. They don't really have any impact on us today for what we're talking about. So pie chart kind of looks like that. About 4/5 nitrogen, about 1/5 oxygen, and some other stuff. Atmospheric pressure. So atmospheric pressure, for those of you who aren't familiar with atmospheric pressure is effectively the weight of the atmosphere on top of us as it's being pulled down by gravity or pulled towards the earth by gravity. So at sea level, we talk about 1 atmosphere of pressure. What does 1 atmosphere of pressure mean? Well, we abbreviate that, pardon me, as 1 ATM. It should be lowercase, actually. That's my mistake. I think I used uppercase throughout this presentation. It should be all lowercase. 1 atmosphere of pressure is about 14.7 psi, or about 101,325 pascals, or about 100 kilopascals, give or take. We can kind of shave off that remaining 1 there. So what that means is if you're standing at sea level, averaged out across the planet Earth, standing at sea level, the weight of all of the air above you, all the way up to the end of the atmosphere, weighs about 14.7 pounds per square inch, or about 100, exerts about 101 kilopascals of pressure. Why is that important? Well, as we start going into subaquatic pressure, we start talking about our pressure differential between what our bodies are used to experiencing at the surface and what sort of pressures our bodies experience as we're underwater. So at 0 meters, at sea level, there's 1 atmosphere of pressure in green there on the end here. There's 0 atmospheres of subaquatic or water pressure. So we have you're 0 meters deep, you're 0 feet deep. There's no additional water pressure pushing down on you. There's just the 1 atmosphere of air in the air column above you. If you jump into the water, you go down about 10 meters. The weight of that water at 10 meters is about the same as the weight of all of the air that was above you when you were standing at sea level. So when you get down to 10 meters, you've added 1 atmosphere of pressure, and you've got a total of 2 atmospheres of pressure, two atmospheres of atmospheric pressure and subaquatic pressure being exerted on you. You go down to 20 meters, that goes up to 3 atmospheres, go up down to 30 meters, up to 4 atmospheres, and so on and so forth. It's important to recognize that at sea level, you have 1 atmosphere of air pressure on you, but 0 atmospheres of like additional pressure on top of that atmospheric pressure. I hope that makes sense. If we're struggling already, feel free to raise a hand or something like that to Anna, but I'm going to try and keep pushing through. So next up, we have something called Boyle's Law. If there are any Brooklyn Nine-Nine fans in the room, I hope you'll understand that Detective Charles Boyle did in fact invent this. That's a total lie. It's not true at all. Boyle's Law is a law of physics that relates to how pressure and volume are linked together. A really short version, the takeaway that we need for today is that pressure and volume of gases, specifically gases, pardon me, are very, very closely linked. So as pressure increases, as we increase the pressure on something, on a container, the volume of the container, all other things being equal, the volume of the container decreases. As pressure decreases, the volume of the container increases. There are some fluctuations with this that revolve around temperature and some other factors. We're not going to worry about those right now. What we're really worried about is the pressure and volume relationship. The other stuff we're going to just ignore for now. So the actual law written out in plain English is for a fixed amount of an ideal gas kept at a fixed temperature, pressure and volume are inversely proportional. So you increase the pressure and the volume goes down. You decrease the pressure, the volume goes up. Right? There we go. So what does that mean for us for diving? Well, when divers are at the surface and they're 1 atmosphere of atmospheric pressure above them, all the gas in their lungs, for example, is this. Let's say it has a unit of 10, right? So at the surface, you've got this thing that has a unit of 10. As you go down into the water column, the pressure around you increases, the pressure on the diver increases, and the volume of that gas decreases. It becomes more dense and more compressed. And the farther down you go, the more compressed and more dense it gets. Next key concept, gases dissolve in solution, or gas dissolves in solution. Do you like how I changed the tense on that slide without even thinking about it? So gas dissolves in solution. As environmental pressure increases, so as we have an increase in pressure, right, the potential for gas to dissolve into solution also increases. So the higher the atmospheric pressure, the more gas we can force into a dissolved solution of liquid. The higher the pressure, the more gas can dissolve into the liquid. As a common example, this is the example that we always use when we're learning to dive and all this sort of stuff. Think of a carbonated drink can. Think of a drink bottle, like a bottle of Coke or a bottle of that new bubbly stuff or whatever. The contents are stored under pressure to keep the carbon dioxide that actually provides all that carbonation dissolved in the fluid of the drink. When you open the can or you open the bottle, you release all of the extra pressure in there, and the gas starts bubbling and fizzing and coming out of solution over a period of time. So you crack open your bottle, you crack open your can, and you'll see it bubble and fizzle for a while until it reaches equilibrium again. Once it's reached equilibrium again, all the gas that's going to come out of solution at whatever altitude you're at will have come out of solution, and then your pop or your drink is flat again and kind of tastes gross. So how does this relate to human physiology and biology? Well, I'm glad you asked. So a little bit of a recap on some stuff. I think most of us are probably pretty familiar with the physiological concepts here, but blood carries oxygen to body tissue and removes carbon dioxide. Blood goes round and round, air goes in and out. Any deviation is a bad thing. Your blood moves around, it takes oxygen from your lungs. So we'll start that again. Air goes into your lungs, oxygen crosses the alveolar boundary from the lungs into your blood. The oxygen is carried around to your cells. Your cells use the oxygen. They off-gas carbon dioxide back into your blood. The carbon dioxide is then carried all the way back to your lungs, crosses the alveolar boundary again, and is breathed out. So what's blood made out of? Now, we talked a little bit about this last week with Jeff Kopp's presentation, which was fantastic. I don't know if you're in the audience tonight, Jeff, but that really was a great talk last week. Thank you. Blood is made up of really 4 things, 4 key components. Made out of plasma, red blood cells, white blood cells, and platelets. Inside the red blood cells is something called hemoglobin. Hemoglobin is a molecule that allows oxygen to bind to it. It carries the oxygen around, and then when it gets to your various cells and organ tissues, it takes the oxygen, it gives it up, it takes on the carbon dioxide. So that's how most of the oxygen in your body actually gets from your lungs to your tissue, is it binds to the hemoglobin. When the oxygen is released into your cells, carbon dioxide replaces it on your hemoglobin, so it becomes carboxyhemoglobin, and the carboxyhemoglobin is carried inside your red blood cells, carried all the way back to your lungs. where the carbon dioxide is then switched out for fresh oxygen coming into your lungs. You breathe out the carbon dioxide, you have now oxyhemoglobin that carries more oxygen around, and around and around and around from really fairly shortly after you're conceived until the day you die. So that's how we get most of our oxygen, around our bodies. However, gas is also dissolved in plasma and carried throughout the body to and from the lungs. So in the same way that we have carbon dioxide dissolved into a bottle of Coca-Cola, we also have a bit of oxygen, a bit of nitrogen, all dissolved into our blood plasma, which is a significant component of our blood volume overall is the plasma, right? It's not a primary mechanism for conveyance of oxygen and carbon dioxide. You'd have to ask a hematologist for all the details on exactly how and why that's not the case, but we do have dissolved gas in our plasma, right? Incidentally, the ability of plasma to carry dissolved gases is why anemic patients can still benefit. So anemic patients who don't have sufficient red blood cells or iron content, can still benefit from supplemental oxygen therapy, even if their SpO2 is 100% and all their hemoglobin has oxygen bound to it, but they're still not quite getting enough oxygen because they don't have enough red blood cells. We can sometimes give them a little bit of supplemental O2 and actually force more oxygen into their plasma. So neat trick. So Henry's law, the amount of any given gas that will dissolve in a liquid at a given temperature is proportional to the partial pressure of that gas in equilibrium with the liquid and solubility coefficient of the gas in the particular liquid. What does that mean? Well, it's the basis for something called partial pressures. We're going to be talking partial pressures a little bit. So if 1 unit of gas is dissolved at 1 atmosphere, and then you double the pressure, right? Then 2 units of gas can be dissolved into the same amount of liquid at double the pressure. If you triple the pressure, you can dissolve 3 units of gas into the same amount of liquid. So what does that look like? At 1 atmosphere, we have 20 molecules of something in the atmosphere and 20 molecules of something in liquid. We double the pressure, we go down to 2 atmospheres, we can actually increase the relative density of a gas dissolved in the liquid by increasing the pressure. What does that look like when we're actually looking at blood? Well, when we're looking at blood, and this is, I apologize, by the way, this is like really old Photoshop art, big air quotes around that I did myself several years ago, and I just didn't have time to do an updated graphic for you guys. So this is what you got, I'm sorry. So, you have one oxyhemoglobin molecule there with 4 oxygen molecules bound to it in the first slide. There's 1 little oxygen molecule floating around, and there's 4 nitrogen molecules floating around. We go down to 2 atmospheres. We double our atmospheric pressure. We still have our 1 hemoglobin with 4 oxygen molecules bound to it. Because we've doubled our partial pressure of oxygen, we have 2 oxygen molecules floating around in the plasma. And because we've doubled our 4 nitrogen molecules, we now have 8 nitrogen molecules floating around in solution. We go down to 5 atmospheres, 40 meters. We still have our 1 oxyhemoglobin molecule with 4 oxygen molecules bound to it, but we have 5 oxygen molecules bound in plasma solution, and we have 20 nitrogen molecules floating around, or not bound in dissolved in plasma solution, pardon me. So this becomes very important shortly. Partial pressure is the notional pressure, the imaginary pressure of a gas if it occupied the entire volume of the original mixture. So what that means is that the total pressure of an ideal gas mixture is the sum of the partial pressures of each individual gas in the mixture. At 1 atmosphere at sea level, everyone has a partial pressure of oxygen of 0.21. So our atmosphere, you got 1 atmosphere, 1.0 atmospheres, 21% oxygen works out to about a partial pressure of 0.21 oxygen, a partial pressure of nitrogen of 0.78, and then that other 1% of trace gases that we're not caring about today, right? So, for example, and this is where things start to hopefully come together a little bit. If a diver is breathing air at 2 atmospheres, 10 meters below sea level, the gases dissolved in their body have a partial pressure of 2.0. So they have an oxygen partial pressure of 0.42. They're at 2 atmospheres times 21%, works out to 0.42, or a nitrogen partial pressure of 1.56. So 2 atmospheres times that 0.78 or 78% works out to 1.56. We take that same diver down to 3 atmospheres or 20 meters below sea level. The gases dissolved in their body have a partial pressure of 3. So we have an oxygen partial pressure of 0.63. We have a nitrogen partial pressure of 2.34. Again, multiplying out 3 times 21%, 3 times 78%. Those are the numbers we get. Right? And again, disregarding our sort of 1% trace gases and thermal variation, all that fun, exciting stuff. So let me explain. No, there was a lot there. Let's try and sum up. So when a diver descends from the surface, goes down, the ambient pressure increases, right? Pressure gets bigger and bigger and bigger. The density of gas in the diver's lungs increases. The partial pressure of gas dissolved in their blood plasma and solid organs increases. So as we go down, pressure increases. That forces more gas into solution in the diver's blood. And that also in turn forces more gas into solution in the diver's body tissue. So their solid organs, their muscles, their nerves, their everything, right? The end result is that more gas molecules are dissolved into blood and tissue. As we go down, we dissolve more gas molecules into our blood and all of our other tissue. When a diver ascends, when a diver comes back up to the surface, the ambient pressure decreases, right? So we're coming back up. We're coming from 20 or 30 meters down, back up, back up. There's less water, there's less pressure. The ambient pressure decreases. The density of gas in the lungs decreases. The volume of gas in hollow organs and spaces, so the lungs, the sinuses, the GI tract. We're going to talk about lungs and sinuses and gas volumes more later on. But the volume increases and the partial pressure, and so the overall pressure decreases. And the partial pressure gas dissolved in the blood plasma and the solid organs also decreases, right? As partial pressure decreases, less gas is able to remain dissolved in the tissue, right? So we're reducing the overall ambient pressure. Less gas is able to stay dissolved in your tissues and has to go somewhere. Gas that comes out of solution increases in volume. So it's gone from being dissolved to coming back and being a gas. And all that gas that's coming out of solution has to go somewhere, right? Again, same idea as a carbonated soft drink. You crack the bottle open, all that gas has to come out of solution. So what does it do? It forms bubbles, and then those bubbles, do various spectacular things depending on how fast you crack open the bottle top. So as a diver ascends, comes up gradually, gas that comes out of solution forms very, very small bubbles, right? That get picked up in your bloodstream, they get carried to your lungs, they pass through the alveolar wall, and they're exhaled, right? So that gas diffuses through, don't pass through. Some of them can pass through, I suppose. They diffuse through the alveolar wall. And the gas is exhaled. So how do we manage this? So divers are trained to limit their dive times, which decreases how much gas can dissolve into them, because gas doesn't dissolve like that. They go down to a certain depth or to a certain pressure. And then the longer they're there, the more gas has an opportunity to dissolve into their tissues. So divers are trained to limit their dive times, which decreases or limits how much gas can dissolve into them. And they're also trained to ascend at specified rates. So they're trained to ascend not fast, but to ascend at different rates or at slow rates to allow their body time to get that gas from their tissue back into their blood, back to their lungs, and breathe it out. A group of people called technical divers are much more highly trained than standard recreational divers. They will spend extended periods of time at certain depths to allow them to decompress. So they'll go down very deep, and instead of just coming up slowly, they'll actually come up to a certain depth. They'll hold their depth for often quite long periods of time to allow their body time to get all of that gas out of solution, breathed out, before they continue coming the rest of the way up. Some technical divers breathe enhanced gas mixtures. So instead of having that 21% oxygen and 78% nitrogen mixture that we've talked about a whole bunch, sometimes they'll actually breathe different gas mixtures. So they'll breathe 50% oxygen, 50% nitrogen. Sometimes they'll breathe different mixtures at depth. It's what something called trimixes. So they actually start replacing the nitrogen with helium to change the gas dissolution characteristics and actually sort of hack your own physiology a little bit to modify how you absorb gas and what that gas that you're absorbing does. We won't go down that rabbit hole too much farther. Okay, that was a lot. Does anyone have any questions? Here's a cute picture of a dog. And in fact, Maddie, come here. Come here. Maddie, come here. No. Maddie, the dog in this picture, is sitting behind me right now. I was going to see if she wanted to come over and say hi, but she's far too interested in napping at the moment. Does anyone have questions? Anna?
So there is a two-part question for you, Nick. Do the ratios of gas absorbed change based on the gas mix?
Yes. Short version, yes. We're not going to go down that rabbit hole too far. But some gases absorb faster, some gases absorb slower, some gases come out of solution faster, and some gases come out of solution slower. And depending on what you want to do and what you're trying to do, playing with those ratios and absorption and desorption speeds can dictate what gases you want to breathe on technical dives.
And the second part, if someone was breathing 100% oxygen, would they still only go to 0.42 at 1 atmosphere?
Great question. No. So if you're breathing, don't forget that partial pressure is a relationship of the pressure to the gas that you're breathing. So if you're breathing 100% oxygen at the surface, you have a partial pressure of oxygen of 1.0. You go down to 2 atmospheres, you have a partial pressure of oxygen of 2.0. If you're breathing 50% oxygen at the surface, you have a partial pressure of 50%, or an oxygen partial pressure of 50%. If you go down to 10 meters, you have an oxygen partial pressure of 100%. And if you're breathing 50% oxygen, 50% nitrogen at 10 meters depth, you would have a PPO2 of 1.0, and you'd have an N2O2, a PPN2 of also 1.0 for a total of 2, because you'd be at 2 atmospheres. I hope that makes sense. Crickets, silence.
That's the only question that popped up in the chat, and David says makes sense.
Fantastic. Okay, we're going to move away from the cute dog pictures, and we're gonna press forward a little bit. So we're going to talk about what can go wrong with dives, as you guys are probably figuring out from all of this sort of deeper physics stuff. There's a lot that can go wrong with dives. Diving is actually, if you follow the rules and follow your training, diving is actually an incredibly safe sport. The rates of injury, as long as people are following guidelines and following sort of the good science, are quite low. But there's a lot that can go wrong if either people don't follow the rules intentionally, or accidents happen, or what have you. So things that can go wrong: the bends or decompression illness. We're going to talk a little bit about that. We're talking about arterial gas embolisms, which are very exciting and very unpleasant. We're going to talk about barotrauma to the ears and sinuses. We're going to talk about seizures at depth. Did you know oxygen can be toxic? It's really interesting. We'll talk about that in a sec. And we're talking about nitrogen narcosis as well, which isn't really an emergency or something going wrong, but is a very problematic effect that divers do have to deal with, and it can result in emergencies happening. So having said that, we've talked about bubbles form in blood, right? So you come up slowly, you come up from a dive very slowly, and bubbles will form in your blood. If you're lucky, the bubbles will be very small. They'll be carried back to your lungs. We're talking about tiny little micro bubbles, right? They'll be carried back to your lungs. They'll lodge in the alveolar walls. The gas will diffuse across the alveolar membrane. You'll breathe it out, no problem. Everyone's happy. You finish your dive, go for a beer. It's a great day. Bubbles that form when you bubbles that form in venous blood are carried to the lungs. Bubbles that form, if they're small enough, if they're little micro bubbles, even the ones that form in arterial blood actually make it through the alveolar bed, or the capillary bed, pardon me, and back to the lungs. So, Bubbles that form in venous blood are carried back to the lungs, provided they're not massive, will diffuse across the alveoli and be exhaled. Right? Bubbles that form in arterial blood, now we're talking about like larger bubbles, right? Say divers coming up a little bit too fast, right? If they're coming up a little bit too fast, the bubbles that form in their venous blood are still going to get carried to the lungs, and they'll just diffuse a little bit less efficiently, but they'll still diffuse across the alveoli and be exhaled. But bubbles that form in arterial blood, if your diver's coming up too fast and those bubbles are forming and they're getting so big that they can't pass through the capillary beds. They're getting so big that they can't actually make it all the way back to the lungs. They start to form what are called gas emboli. Emboli is just a fancy medical word for lumpy thing in an artery that blocks blood flow, basically. You can have fat emboli, you can have gas emboli, you can have rouleaus, which are clot emboli. But if your bubbles start to form in arterial blood, you get what are called gas emboli that start to obstruct blood flow. And of course, they start to obstruct blood flow in generally speaking bad places. If they're in the venous system, they still come back to the lungs. They lodge in the lungs and they diffuse across the membrane, and off we go. If they're in the arterial system, though, where do your arteries go? Well, your arteries go to your heart and your brain. And depending on the size of the bubbles will restrict blood flow or occlude blood flow to certain parts of those organs. And as you guys are probably aware, I hope you're aware, your heart and your brain are both fairly critical to being alive. So what we get are effectively massive stroke-like events, or potentially massive stroke-like events that impact the heart and the brain, right? Arterial bubbles don't have, or arterial gas emboli, don't have to be rapidly fatal, but they certainly have a significant potential to be lethal, right? We're going to talk about other causes of arterial gas embolisms in a few slides here, but other causes of arterial gas embolisms can include pulmonary barotrauma, so popped lungs, cardiac right-left shunting, such as atrial septal defects and patent foramen ovales. Atrial septal defects are PFO is a type of ASD. Is basically I don't think I have a slide on this. I'm sorry, I should have. Basically, a hole in between the right atrium and the left atrium of your heart, in between the two atria. If you guys can see me, in between your right atrium, I'm backwards on the camera, I think, but this is my right side. So between your right atrium and your left atrium, there is a septal wall. And if you have a small hole in that septal wall, venous blood can pass through from the venous side to the arterial side. And so those bubbles that would normally be going to your lungs to get caught in that sieve of the alveolar bed and then exhaled, don't make it there. They just get dumped straight into the arterial system, where they go forth and wreak havoc in various places. They get caught in coronary arteries, they get caught in cerebral arteries, and bad things happen. So what's DCI? Decompression illness, commonly known as the bends. A lot of people have heard of the bends, don't necessarily know where the term comes from or what it means. That's what we're going to talk about for a little bit here. So if divers ascend too fast, we've talked about this already, covered this already. Gas comes out of solution faster than it can be carried to the lungs. Bubbles form in blood. We just talked about that. Bubbles form in other spaces. What other spaces might bubbles form in? Well, there's a whole bunch. None of them are good. I think I have another slide later on this, so I'm going to hold that for a second. The effects of bubble formation are categorized as type 1 or type 2 DCS. So type 1 is minor DCS, type 2 is neurologically involved DCS, decompression sickness, decompression illness. And some sources, depending if you're doing any further reading, some sources will refer to arterial gas embolisms as type 3 decompression sickness. It's a bit of an academic nuance, I think. It's not that common in usage. So bubbles form in other fluid spaces. So we talked about, I said, bubbles form in other spaces. What other spaces? Well, they form in synovial fluids in joints, right? So your synovial fluid in your joints, and I do have a slide on this to illustrate this later, is very poorly vascularized. There's not a lot of blood flow near it. So it's relatively easy for gas to go into solution in the synovial fluid in between your joints, but it does take a lot longer for gas to come out of solution in the joints. And if you get fluid there, the gas isn't coming out of solution because it doesn't have as ready an exposure to the blood because it's not very well vascularized. Those bubbles will form, and they'll actually form in the synovial fluid itself. Synovial fluid is one of the most common sites to get bubble formation in dive injuries, and that characteristic joint pain, as you can imagine, it's like the worst arthritis you can possibly imagine. The characteristic joint pain that comes along with bubble formation in joints is what makes people double over and get bend over, which is where the name the bends comes from. Other fluids that have terrible vascularization, vestibular spaces, so that your inner ear, the fluid in your inner ear, also very easy or relatively easy for gas to go into solution and sort of dissolve across all the tissue and end up in the fluid of your inner ear there. Much more difficult for it to come out of solution. So if you're going to get bent somewhere, your vestibular spaces are among the more common places that you might have gas bubble formation. What does that do? Well, if you guys are familiar with how the vestibular system works, it's a whole bunch of cilia, little hair, fiber things, a bunch of fluid that goes back and forth across the cilia that gives you your sense of balance. We throw a bunch of bubbles in there and they start knocking around in all those cilia, all those hair. You get horrible, horrible vertigo. Vestibular bends are like the worst thing ever. I've never had one myself, but I've seen people with vestibular bends. They're sure not fun. Right. Where else does bubble like to form? I should have said bubbles form in other spaces, not other fluid spaces on this slide. Bubbles form in adipose tissue. Why do they form in adipose tissue or fat tissue? Adipose is just a fancy word for fatty tissue. Well, nitrogen is highly soluble in fatty or adipose tissue. So, your muscle tissue can absorb a certain amount of nitrogen. Your fat really likes to absorb nitrogen. It goes in really, really easy. It comes out of solution really, really easy, which means that when it's coming out of solution really, really easily and really, really quickly, if you come up a little bit too fast, it might not have the opportunity to get carried into your bloodstream, off to your lungs, and breathed out again. So why is that a problem? Well, it's most of us have a reasonable concentration of adipose tissue around the waist, around the breasts, around the thighs, around the buttocks. So we can see a certain type of mottled rash. I'll show you some pictures of that in a minute. As we get what are called skin bends or cutaneous bends. They're relatively harmless themselves, but they can be a good indication that something else is going on as well, that a person ascended too quickly and is at fairly high risk of other types of decompression illness as well. More problematic with adipose tissue, there's that point. More problematic in adipose tissue is that myelin, that fatty stuff that lines all of our nerves. Myelin is a fatty tissue. You need to talk to a biochemist to get all the details on this. But nitrogen really likes to go into solution in myelin. It really likes to come out of solution in myelin quite quickly. And so frequently, not always, but frequently, we can see bubble formation that are directly localized around nerves. And as you can imagine, when you start getting bubbles that form around nerves that start then impinging on those nerves, putting direct pressure on them, we get all kinds of neurologic sequelae that we're going to talk about a few more slides down the road here that can be very, very problematic. So part of the reason that we worry about when we see someone with skin bends, the skin bend itself is itchy, uncomfortable, might be a little bit painful. The skin bend itself is not a major issue. The Cutest Marmarata, the name of that fancy rash, is not that big of an issue. But what is a big issue is that if they've got that, there's a very reasonable chance that they're probably also nucleating nitrogen bubbles or helium bubbles or whatever bubbles in other areas of adipose tissue as well, including myelin sheath nerves, and that's a problem. So this is what Cutest Marmarata looks like. The slide on the left with all the white fabric there, I have no idea where I got that from. That was from an old version of this presentation that I gave years ago. On the right-hand side is an example of Cutest Marmarata provided to me by a friend at Koh Tao Rescue in Thailand, where I was a long time ago. But that's one of their patients that's agreed to have this shared with permission as well. Talking about talking about that synovial fluid. There's just a little reminder here. I think you guys are probably familiar with this concept, but joints like this, you have two joints, two ends of a bone. You have a sac, and then that sort of encapsulates that joint, some cartilage to provide friction reduction. And then within that sac and in between the layers of cartilage, we have synovial fluid that just basically provides lubrication between two ends of the joint. It's inside that synovial fluid that we often get bubble nucleation during dive injuries. So moving on to a little bit of neurology. Nitrogen dissolves easily in fatty tissue. We talked about this. The myelin sheath that encircles nerves is a fatty tissue, or that helps insulate nerves is a fatty tissue. Bubble formation is frequently seen around turf tissues. Turf tissues, that's a new scientific term right there, and nerve tissues, and may compress nerves, causing paresthesias. So in the same way that we can get paresthesias when nerves are directly impinged, when they're squeezed, when there's been direct trauma to them, a bubble gets in beside them, especially in the spinal cord. It starts to compress areas of the cord or compress areas of the where innervation is leaving the spinal column. Starts to actually compress those nerves. We start to get all kinds of paresthesias, right? So numbness, tingling, lack of motor function, and so on and so forth. Depending on the location of the bubble formation, some localization can be accomplished by noting localization of where the bubbles are, that is, can be accomplished by noting which dermatomes are affected. So if you guys have ever seen a dermatome chart before, we can actually make, to some extent, inferences about what nerves are being impacted or what area of the spinal column is being impacted by bubbles by noting where people are having numbness and tingling. I don't expect you guys to be putting this into practice anywhere, but this is a worthwhile thing. If you're practicing at a level where this would be a reasonable thing to incorporate into your practice, you're probably aware of that already. Certainly for the MFRs, please don't start doing dermatome charts. But do note if someone has a numb thumb and then a numb hand later on, all this sort of thing. So symptoms, two types of DCI. I talked about type 1 and type 2. Type 1 often is gradual onset, often accompanied by joint pain, right? We talked about that. Unexplained fatigue. The unexplained fatigue is more from sort of like a broad physiologic stress that comes about from massive bubble dissolution, systemic bubble dissolution. Localized edema, often or generally in this context, the result of parts of your lymphatic system, pardon me, I just blanked on that there for a sec, parts of your lymphatic system getting physically blocked by bubbles and preventing lymphatic drainage from particular areas, and you'll actually get localized swelling in hands, feet, legs, other parts of the anatomy. I know one friend one friend who I dove with in another country, and I'll leave it relatively anonymous at that, who actually had part of the lymphatic drainage from one of her breasts occluded, and actually had localized edema of one breast until she got recompressed and had it resolved. Other things that people can get, niggles is sort of a colloquial dive term, but niggles would be, there's just something, it just doesn't feel comfortable. There's something going on here. I'm not quite sure what it is. Cutest Marmarata, as well, as we sort of talked about. Type 2 decompression illness also has gradual onset, but with neurological involvement. So central or peripheral nervous system involvement, peripheral nerve involvement, we already talked about. So that's those paresthesias, that numbness, that tingling, that impaired motor function. Can look to some extent slightly, well, I guess all of us can look CVA-ish, but you'll have one-sided weakness or one-sided numbness in just one arm or one leg or something like that. Might be transient or migratory, so it could move around, it could resolve spontaneously, it could come back. It's important to remember that type 2 DCI can also involve the central nervous system as well. And central nervous system, for those of you who aren't super familiar, the peripheral nervous system is sort of everything from your spinal column out. The central nervous system is your brain and your spinal cord. And so symptoms like confusion, aphasia, disorientation, various other types of speech impediment, memory loss, loss of consciousness, all this sort of stuff that could otherwise be, or might otherwise look like a cerebrovascular accident, can also be, and certainly in the context of someone who's been diving recently, should be treated as if it's a dive injury, because they could actually have bubble nucleation in the brain, either in the tissue itself or occluding arteries within the brain and occluding blood flow to certain regions of the brain, which could of course cause infarction, pardon me. So what does gradual onset mean? We use gradual onset a bunch here. Gradual onset for type 1, type 2 DCI. Oh, I don't have a slide for type 3. I'm so sorry. So type 3 or arterial gas embolisms are not gradual onset. Arterial gas embolisms come on very, very fast. They typically happen, they typically happen most frequently when someone has ascended so fast that they've actually had a pulmonary trauma and they've actually popped a lung. We are going to talk about that. There's a slide for that stuff later. So what does gradual onset mean? Well, gradual onset means that symptoms for most divers will present within 1 hour. 42% of the people who are going to get dive injury or type 1 or type 2 DCI symptoms will have them within 1 hour of surfacing from their dive. Pardon me, I should clarify that, of surfacing from their dive. 60% within 3 hours, 83% within 8 hours, right? So just because you popped up from your dive and you managed to get away with everything, and those bubbles are still starting to percolate, they're still starting to come out of solution, it might take them up to 6-8 hours to come out of solution enough to have you start to experience symptoms, right? So just because you finished your dive, got back on the boat, and made it all the way back to shore doesn't mean you're not bent yet. Within 24 hours, 98% of symptom onset within 24 hours, and within 48 hours, we see 100% of symptom onset. We do, and anyone who's a certified diver or has undergone any kind of dive training will know that they're not supposed to fly within, I actually forget what the official recommendation is. I think 48 hours. A lot of people extend that to 72. The reason, of course, being that when you get on board any kind of commercial aircraft, whether it's pressurized or not, you do end up in a hypobaric environment, and so you can actually, you go up to altitude, and you can actually encourage more gas to come out of tissue and stuff. So these numbers are presuming no commercial flight or anything like this. Someone who's come up from a dive and stayed relatively close to sea level. So pulmonary barotrauma. This is a big topic that I'm going to try and cram into 2 slides. So pulmonary barotrauma is usually the result of overpressure in the lungs if a diver ascends too quickly without breathing out fast enough. So if you hold your breath and come up, and all that gas inside your lungs expands and expands and expands and expands and expands, your lungs are just like a big old balloon. Eventually something's going to pop. Now they won't pop catastrophically like an overinflated latex balloon, but they will develop small tears, maybe even a large tear potentially, that can result in gas bypass, either A, into the arterial bloodstream. It's quite possible because your lungs are very well vascularized with arterial blood, or B, gas bypass into the thoracic cavity, which can lead to a pneumothorax and a tension pneumothorax. And it's important to recognize that we often think of pneumothoraces and tension pneumothoraces as being traumatic related events. And certainly in some elderly people, we might see a spontaneous pneumo or potentially even a spontaneous tension pneumo. But often we think of a pneumothorax or tension pneumo as being something that's secondary to a major traumatic event of penetrating or blunt force injury to the chest wall somehow. In divers, simply the act of ascending too fast can pop a lung and result in an internal closed pneumothorax. For those of you who are watching who may have the capacity to do chest darts or needle thoracenteses, something to keep in mind as well. Just because there's no external trauma, just because there's no trauma, an otherwise healthy person can in fact pop a lung this way and vent gas into their thoracic cavity. We can also result in gas bypass into the subcutaneous space. For those of you who remember this from their OFA 3 or from their MFR or whatever, that subcutaneous emphysema, that snap, crackle, pop, it's a very, very specific and remarkable feeling. It's not super common. We don't see it a lot, But it's a very, very unique finding. If you do find sub-Q emphysema in someone who's had a rapid ascent from diving, you should assume that they have a pulmonary injury, and you should assume that they're at high risk for gas bypass into their arterial bloodstream and gas bypass into their pneumothorax, or into their, pardon me, into their thoracic cavity, resulting in a pneumothorax or a tension pneumothorax eventually, right? Bubbles that form in arterial blood, here's the slide I was thinking of, are carried to the capillary beds or small arteries where they form gas emboli and obstruct blood flow, right? So they can, if we form larger bubbles, they'll obstruct blood flow in the capillary bed, or they'll even get large enough that they can obstruct blood flow in arteries themselves. AGE can present with often catastrophic neurological symptoms, just like a stroke, which is often a clot. 85% of strokes are ischemic strokes, where a clot has traveled somewhere. 15% are hemorrhagic strokes. Of those 85% that are ischemic strokes, this is exactly the same mechanism, except instead of a blood clot, it's a bubble of gas. So that bubble of gas can travel somewhere. It sort of gets lodged there and basically causes a portion of the brain to infarct. Arterial gas embolisms can present with often catastrophic cardiac symptoms. So what's attached to your heart? Well, your aorta. And what's attached, or what feeds from your aorta immediately beside the heart? Your coronary arteries. So if those bubbles start to form, especially for folks that have PFO or another type of atrial septal defect, which is incidentally a very large portion of the population, something like 25 to 30% of the population is wandering about with a PFO of some size or another. Those people might end up with significant gas buildup in the left atrium and then the left ventricle. And then when that comes out of the left ventricle, it goes into a coronary artery and lodges and occludes a large chunk of a coronary artery and can result in a cardiac infarction as well. Right? AG can result in significant hypoperfusion injuries to other organs. Most other organs are more resilient to hypoperfusion and less immediately life-threatening than your heart and your brain. Your heart and your brain are the two things that are going to be massively problematic in the field in terms of management. AGEs, AGEs are, broadly speaking, fairly catastrophic events. The textbooks say that there's a relatively positive prognosis if they're treated rapidly. I'm not directly familiar with the numbers. I don't have the numbers in front of me on that. Just because they have a positive prognosis if they're treated rapidly doesn't mean you need to do anything other than treat them rapidly and fairly aggressively, depending on what you have access to in terms of interventions. Moving away from the catastrophic stuff, sinus barotrauma. This is one of the pictures that I shamelessly randomly found on the internet and grabbed. Sinus barotrauma is, as you might expect, sinuses. We're talking specifically the cranial sinuses. Are gas-filled pockets inside your skull. When you get a pressure difference in between the sinuses, the lungs, and the mask space, you get pressure differentials, and as you go up and down in the water column. And at some point, something has to give to help rectify that pressure differential. Now, normally, in a normal healthy person who doesn't have any sinusitis, doesn't have any kind of sinus infection, doesn't have inflamed sinuses, doesn't have very small eustachian tubes, all this sort of stuff, the gas exchange is unimpeded in between the sinuses, the lungs, and the mask space, and this isn't a problem. People who go diving when they have a cold, people who go diving when they have inflamed sinuses or an allergy flare-up, people who go diving, and just some people will try to go diving and will find out during their open water course that they actually just have very small eustachian tubes with very poor gas exchange or gas movement through them, will often result or have sinus barotrauma. This is the same process, just to give everyone an analogy, this is the same process as your ears popping with a change in altitude. For those of you in Victoria, if you go up and down the Malahat, you feel your ears pop, you get into a plane, you fly to altitude, you feel your ears pop. It's exactly the same thing, just a little bit more rapidly, and you will, as the divers move through the water column, they're exposed to much greater pressure differentials over a much shorter period of time, allowing for less opportunity for equalization and more opportunity for tissue trauma as a result. Can result in ruptured tympanic membranes. You can pop an eardrum this way. You can have sinus trauma. You can have bloody mucus. If you look at this photo, you'll see all the blood in this guy's mask where he had some sort of mucus plug And the thing that gave way was not the mucus plug. The thing that gave way was the tissue beside the mucus plug, would be my guess looking at this guy. I don't know that. I'm just making inferences from the photo. Sinus barotrauma sucks. It's unpleasant. There's often a lot of blood. There's often a lot of blood mixed with water, which makes it super, super messy. They're not normally life-threatening. If there's vestibular involvement, if there's tympanic membrane involvement, there's significant potential for infection. There's potential for vestibular involvement and balance disruptions, vertigo. These people absolutely need to go see a physician. If it's just a nose sinus barotrauma and they bled a little bit and then it stopped, probably doesn't necessarily need a referral to medical aid, at your discretion, depending on what your indications are and what else is going on. But if it's just an isolated sinus, like nasal sinus barotrauma, they're not super uncommon. Seizures at depth, we talked about oxygen partial pressures and stuff. So when we get oxygen partial pressures higher than about 1.4 to 1.6, give or take, and specifically the risk goes much higher when we go to 2, we can actually have the hyperoxic environment inside our body can actually basically cause a short circuit in the brain and cause seizures. Hyperoxic seizures in hyperoxygenated environments, high pressure hyperoxygenated environments, are very poorly understood. They're very difficult to predict, other than we know that if you keep your PPO2 lower than 1.4, you have a much reduced chance of having a hyperoxic seizure. Physiological stress, cold water, and exertion are all suspected to contribute to hyperoxic seizures. Like most seizures, the hyperoxic seizure itself is not dangerous on its own. It's a seizure, it'll resolve, you'll be a bit post-ictal afterwards. But seizing underwater when you're on a life support system that you have to monitor and keep the regulator in your mouth and all this sort of thing, a seizure in that environment is very likely to make you spit your regulator out and suck in a lungful of water while you're in a pressurized environment that requires you to ascend slowly so you don't get decompression illness. And so it's all the sequelae from that seizure that are more likely to be dangerous to you than the actual seizure itself. Hyperoxic seizures are not generally a risk factor for recreational divers who are diving on air and who are diving within their recreational dive limits as defined by PADI or NAUI or whoever you're trained with. Part of the reason those limits exist is to limit the potential for hyperoxic seizures, right? So you don't actually go exceeding that PPO2 of 1.4 or 1.6 when you're in air mixture. Nitrogen narcosis, or rapture of the deep, as it was called back in the 1950s, 60s, and 70s, and as old people still call it now. Nitrogen narcosis is something that happens when your PPN2, your nitrogen partial pressure, gets significantly higher. It's similar to the effects of nitrous oxide. For those of you who ever had nitrous before, they're at the dentist or in the back of an ambulance, or for those of you who have consumed alcohol, getting narked, experiencing nitrogen narcosis does feel quite a bit like being drunk. I have been very, very narked quite a number of times doing fairly deep dives on air mixtures. Nitrogen narcosis results in impaired judgment, decreased response time, just like alcohol, just like nitrous oxide. Some people, and I can speak personally to this, myself included, do report anxiety, fear, paranoia. I have not had hallucinations, as you guys can see on the slide here. We do have someone hallucinating their buddy is riding a camel underwater. I've never had hallucinations myself. I do know at least 2 friends who have experienced significant hallucinations and believe they were speaking with a turtle, one person, on a dive. The anxiety, fear, paranoia can be very difficult to manage. I was lucky in that I was able to very effectively manage mine. But that can be a really dangerous thing. If you're on a fairly deep dive and you're in a hostile, hazardous environment and you start to get anxiety, fear, and paranoia that could potentially become dysregulated, that can really impair your ability to function and to complete your dive safely. And so it's that secondary sequelae, that sequelae from the narcosis that can be problematic. A few sources have noted that the symptoms of nitrogen narcosis resemble the early stages of general anesthesia. There's a thinking that the physiological process is quite similar. It's You know, we use nitrous oxide for the same things as high ppN2. We expect that the physiological process is probably the same, but there's little science to definitively say that that's the case. Nitrogen narcosis is transient. It resolves immediately or very, very, very rapidly with ascent back to a low ppN2 environment, or by transitioning, if you're doing a technical dive and you have multiple gas mixtures with you, by transitioning to a low nitrogen breathing gas or low ppN2 breathing gas, so switching over to something that has some helium in it or something like that. And avoiding nitrogen narcosis is incidentally one of the main reasons that we use trimix, which is a helium nitrogen oxygen mixture, to dive deep. It's specifically so that we can reduce the amount of nitrogen, A, to help speed decompression, but B, to avoid the dangerous effects of narcosis. The primary risk for nitrogen narcosis is impaired cognitive function resulting in a secondary dive accident. So I see, oh, that's too bad. A friend of mine is sending me some photos that I was hoping I could have included in this. It's just a little bit too late. So dive history. What do we need to know? We've got someone who's had a dive accident. What do we need to know to be able to take care of them effectively? Now, we're going to talk about what their clinical management is going to look like in a minute, but what do we actually need to know about what their dive was like or what got them injured in the first place to be able to pass on to the hospital? Well, there's a few things. We want to know how deep their most recent dive was. We want to know how long their most recent dive was. We want to know if anything went wrong with their most recent dive. Was it a normal planned dive, or was there some sort of catastrophic equipment failure, accident, unplanned rapid ascent, any of these sorts of things, you know, or were they more stressed? Were they really cold? Did they go deeper than they meant to, longer than they meant, any of that sort of stuff, right? Did anything go wrong? How fast was their ascent? So did they come up at a normal ascent rate, or did they come up too fast? There's a bunch of reasons people can come up too fast. You can have a controlled but still too fast ascent, so you're coming up in a controlled manner, but still at still in control of your ascent. Or you can have an uncontrolled ascent. An uncontrolled ascent is where there's been some sort of malfunction in the buoyancy system, or someone's had to eject their counterweight system, come immediately to the surface, but they come up very, very fast. You know, we want to know that if that was the case. What was the diver breathing? Were they breathing an air mixture? Were they diving air? Were they diving nitrox or enriched air? Nitrox is a mixture of nitrogen and oxygen that just has more oxygen and less nitrogen. So you can have 30-70 nitrox, which is 30% oxygen, 70% nitrogen. You can have 40-60, 40% oxygen, 60% nitrogen. Were they breathing something else? Were they breathing an exotic gas like trimix or something else? Find out what they were breathing. If it was non-air gas mixture, what gases and what percentages? What was their mixture? We do want to know as well what the depth, duration, and time of all their dives in the past, let's say 72 hours in the last couple of days at least. As we talked about earlier, when you come up to the surface at the end of your dive, it does take quite a long time for your body to finish off-gassing, for it to finish getting all of the gas that's dissolved in solution in you breathed out. And so when you do multiple repeat dives, even one dive a day for several days in a row, you won't have had time to fully get rid of, depending on how deep and long the dives were, you might not have had time to fully get rid of all of the dissolved gas that was still in your body and in your system from your past dive. And so you get a cumulative effect. The guy in this photo is pointing at what's called a dive computer. A dive computer is, as it suggests, a computer for diving that keeps track of your dive depth, your dive time. It keeps track of your decompression schedule. It tells you how long you can be at certain depths before you have to do decompression, when you need to come to the surface, what your ascent and descent rates are, all that sort of stuff. If you can bring the dive computer with the patient, the dive computers do, generally speaking, log all of that information. And so having access to that and being able to download that computer, even just scroll through it and look at that information, might save you a whole bunch of digging through your patient's dive log, and or can be a really, really valuable resource to the clinical team that's managing the patient farther down the road. So what are some contributing factors to dive injuries? Well, there's a whole bunch. Dehydration. As with many physiological stressors, dehydration just kind of makes everything worse. It decreases your body's ability to get rid of gas out of tissue, or decreases the efficiency at which your body can get rid of gas out of tissue. Alcohol consumption, especially alcohol consumption immediately before a dive, or significant alcohol consumption even the night before, can lead to, is often associated with partying and maybe less responsible behavior and maybe some secondary dehydration from that. Then you get out and go for a 6 a.m. dive the next morning. It's a fairly common story at dive resorts and stuff. Repetitive or aggressive diving. So depending on how deep your dives are, you might be trying to stack as many dives as you can into a trip. That increases your risk factor fairly substantially. Moderate or strenuous activity before or after dives. So jumping out of the water and going for a workout immediately after a dive, for example, going for a workout immediately before a dive. I don't quite understand the physiological basis behind this. I believe it's just an increased metabolism, increases off-gassing to some extent, or metabolic function to some extent that might lead to increased bubble formation is my best guess. I see this cited in a bunch of places, but I don't actually know for sure. Sudden warming after dive. So people who come out of a cold water dive, they go hop in a hot shower, they get massive peripheral vasodilation. Your body starts your metabolism kicks it up a notch. Everything starts just dumping all of this extra gas into tissue, and it actually or into blood, pardon me, out from tissue into blood, and then just sort of overwhelms your lungs' capacity to get rid of gas. Physiological stress, including temperature extremes. So being very, very cold during a dive specifically, being in a very, very hot environment, like tropical environment immediately after dive, just adds to physiological stress and makes things worse. So what do we do with dive injuries? I've talked a lot about this stuff. What do we do with dive injuries? Well, there's a few general principles. First off, anyone who has a dive injury, or what you think has a dive injury, is sicker than they look. Right. Dive injuries have the potential to be rapidly life-threatening. They have the potential to have really significant consequences for your patient, and they can be very evolutionary, which means that you get out of the water, you feel fine for 20 minutes, and then you start to feel a bit of a wiggle and a niggle in your arm, and that stays there for an hour. And you start to get some real joint pain, and that gets worse for an hour or two. And then you start to really have this like headache, and your arm starts to go numb, and so on and so forth. You sort of see this clinical deterioration. So if your patient is symptomatic of dive injury, and they have been diving in the last really 24 hours, you should probably treat them as a dive injury. You should assume that they have the potential to deteriorate rapidly, and deteriorate in ways that might not be inherently obvious or expected to people who are non-divers, not used to dive injuries. So what do? We provide them with high flow oxygen by non-rebreather mask to aid with nitrogen or helium or whatever other diluent gas they have washout. It's important to note that high flow oxygen dive injuries has a twofold purpose. It provides better oxygenation for your very sick patient, even if they don't look sick. And it accelerates inert gas washout from tissue. So what that does, and I don't want to go down another physics rabbit hole talking about osmotic gradients, but what that does is by putting a 100% oxygen environment in the lungs, it helps speed the rate at which nitrogen or helium or whatever other gas they're breathing can pass from the bloodstream into the lungs and then be breathed out. So you are actually helping them decompress faster by giving them high flow oxygen. This is probably one of the only times where you will hear myself or any other professional paramedic say, absolutely, give them as much high flow oxygen as possible, even if they don't look sick. That's a pretty important take home. And if someone argues with you, try and do what you can to keep them going on the high flow oxygen. It's probably one of the best things you can do for your patient. Be prepared for rapid deterioration. Do be prepared for your patient to get worse quickly, potentially. Some people might just get a skin bend and that's it. Great, fantastic. Some people might get a skin bend and it's a prequel to a much more significant neurological event, half an hour, 2 hours later. If your patient's in pain, do not administer Entonox or nitrous oxide. Why not? Because Entonox and nitrous oxide has a boatload of nitrogen in it. And the one thing we're trying to do is to get all the nitrogen, or as much nitrogen as possible, out of this patient. and giving them something that's high in N2 will literally make their dive injury worse and slow recovery. Yes, it can be painful. Yes, it sucks. No, you shouldn't be giving them nitrous. For the medical first responders here, you don't even have that option. That this comment's directed at the PCP, ACP, RNMD crowd that are attending tonight as well. Do treat your dive injuries as if they're a major trauma to a certain extent, at least. Keep them warm. I would strongly suggest bilateral wide bore IV access. Again, this is not directed at the MFRs. This is directed at the professional responders. I'm not telling the MFRs to go and start IVs, please. But yeah, you should expect your patient to deteriorate and potentially to deteriorate rapidly, and you should be prepared for that. I wouldn't necessarily think it would be a bad idea to make sure you could find your suction unit and keep it nearby and all that sort of like prep for deterioration stuff that we do as well. Do keep them warm. Again, minimize physiological stress. If it's like 80 degrees out or something, don't keep them warm. Help keep them in a comfortable environment. Do transport rapidly with early notification to the receiving facility. We're going to talk about what receiving facilities are like. Early notification is really important because hyperbaric chambers, which we're going to talk about in a couple of slides, hyperbaric chambers are A, very expensive, B, very rare, and C, have very, very specialized, highly trained, and very, very few people to staff them. And so very often, if you're coming in with a dive injury, spinning up the hyperbaric team to be able to get to the facility and prep the chamber and stuff for treatment can be a significantly delayed process. There's also possibilities they might have to get other patients out of the hyperbaric chamber because chambers are used for a lot of things other than just dive injuries. And yeah. So other things for management. This actually flash. I don't know how this is going to show up across Zoom, but this is flashing right now in red, which should tell you something. Please do not try to recompress your patient in water. So you might think, well, this person came up too fast. We stick them back in water and send them back down and recompress them. The bubbles will all go back into solution. Then we can bring them up more slowly, and then everything will be fine. Well, you're not technically wrong. The theory is not technically wrong. The problem is that your ability to get that person recompressed deep enough to push all of those bubbles back into solution, keep them there long enough to get those bubbles fully back into solution and bring them up slowly enough to make sure everything comes out of solution properly this time around. It's not something that's feasible in the field. It might be tempting. It might be very tempting to think that you can manage this yourself. I'm going to tell you right now, you cannot. It is a bad idea. Please don't do it. It's a great way to get your patient in worse clinical condition. It's a great way to get your patient severely injured or killed. It's just not something that you should do. I understand the theory. Everybody asks that question. Don't do it. If an arterial gas embolism is suspected, so if you've got someone who's got what you think might be an arterial gas embolism developing, my understanding is that this slide, the information on this is largely theoretical. I haven't found a great deal of clinical research to back this up. However, it's what a number of the textbooks are suggesting, so we're going to go with it for now. They suggest positioning the patient in the Trendelenburg, the feet up and head down position, and rolled to their left. Now, this doesn't mean just raising the feet on the stretcher. Trendelenburg position is actually the entire body at an incline. The reason for this is that it might help prevent bubbles that collect in the left ventricle of the heart from migrating to the aorta onwards to the coronary arteries and the brain. So what you're trying to do is you're trying to use the left ventricle of the heart as a bubble catch. If you've gotten to this point, guys, I really wish you the best of luck. Things are probably going really bad for everyone right now. Do be prepared for rapid deterioration of your patient. If this is where we're at, I think you can probably reasonably expect this person to have a poor prognosis. So what do we do for long-term treatment? Well, we go to what's called a hyperbaric chamber, hyperbaric overpressure, an overpressure chamber. Hyperbaric chamber is basically a big metal container with room for up sometimes 1, sometimes 10, sometimes 20 people that can be overpressurized to simulate taking that person back down into a high pressure environment, force all those bubbles back into solution in the blood, and then bring that person up in a very, very gradual manner, allowing all those bubbles to be breathed out the way they normally would be if the dive had been ended safely on its own. So the primary treatment for dive injuries for DCI, pardon me, not for like the vestibular barotraumas and stuff, but for the actual decompression illness. Primary treatment is recompression in a hyperbaric chamber. Recompression does take many hours and follows strict tables that have been developed over a long period of time, many by the US Navy actually, that dictate the recompression, the equivalent recompression depth, the duration, how much oxygen or what gas mixture the patient's going to get. When I say many hours, a standard US Navy table 6 is, I think, 5 hours or 6 hours or something like that. I got to slide up on it later. And it's not uncommon for people to have to go through multiple table 6 treatments to fully resolve their symptoms. Facilities for recompression are very, very limited. There is only one publicly accessible recompression chamber in British Columbia. It's located at Vancouver General Hospital. You'll see some photos in a second. There is a second chamber for military personnel located in View Royal in Victoria, just outside of Victoria. It's operated by the Navy. It's restricted only to Navy personnel. In terms of your clinical management, again, continue to provide as high percentage of oxygen as possible to your patient. Treat them as if they're going to crash, and go very, very quickly towards whatever your nearest access to a chamber is. Phone early, make dinner reservations, all that. To finish off, a couple of photos. This is what a recompression chamber looks like. This is the Vancouver General Hospital hyperbaric facility. One of my friends was actually in this chamber last week. After a rapid ascent dive accident that he experienced. I am not going to belabor too much about this. It's sort of as you'd expect. There's an airlock on one end allowing staff to come and go into the chamber. You can see an airlock on one side here beside the computer monitors, allowing items to be passed in and out of the chamber. Obviously, there's a lot of high pressure tubing and electronics and compressors and all that sort of thing attached to this. Here's a picture of the computer control console for the chamber. If you look on the right-hand side here, you see all the condensation that's happening in there. That's actually the result of condensation. As the pressure in the chamber increases fairly rapidly, the humidity in the air condenses out. And you actually get a cloud that forms inside the chamber itself. This is the hyperbaric facility. This is a much more sparse hyperbaric facility in Phuket, Thailand. This was sent to me by a friend of mine who I worked with as a dive medic in Thailand many years ago. On the right-hand side, instead of having their own compressors, they've got banks and banks and banks of high-pressure air that they use to pressurize the chamber. You can see just above the bed there, they have what looks like one airlock to pass objects or items in and out. And it's obviously a much smaller chamber facility than the one at Vancouver General. Here's the control console for the Phuket facility. Doesn't look like they actually have a personnel airlock on this one either, which is obviously poses some problems. So your chamber attendant would go in with the patient, and then your chamber attendant's in there until the patient has done their treatment. Just for interest, this is what a US Navy decompression treatment table 6 or table 6A looks like. As you can see, the patient will be breathing different mixtures of oxygen and air at different pressures. The table 6 is 288 minutes, so just under 5 hours long. Table 6A is 350 minutes, so 5 hours and 50 minutes, not including the descent time. This isn't a quick fix. Just to snap someone out of their dive injury, these things take quite a long time. And again, if you have to undergo treatment multiple times under a decompression treatment table like this, 17 hours, 20 hours, 24 hours, maybe with breaks in between, maybe not, depending on how you're presenting and the physician's discretion. Last and not least, I wanted to give a plug for the Divers Alert Network. Dan is a fantastic group. They're a collection of nonprofits that basically work to provide facilitate emergency care for dive injuries, and clinicians providing care for dive injuries. So if you've got a dive injury and for some reason you don't have access to a Canadian 911 system or a 911 system or an EMS system, wherever you are, you can phone these guys. They will give you some advice on how to try and care for your patient. If you're here in BC, please, or Canada, please just phone 911. But these guys can be a good resource as well. If you're a clinician, especially for the physicians in the group who may be in remote areas and stuff, Dan can provide some fairly useful clinical information or clinical guidance to you as well if you somehow end up treating a patient, say offshore or something like that, a significant distance away from recompression or higher levels of care. These guys might be a good opportunity, a good resource for you to look into. References, this is a smattering of the references. A bunch of this stuff came out of my own personal knowledge base, so I didn't necessarily go and dig up direct citations for all of this because a lot of this has been my practice for many years. Special thanks to Mr. Andrew Finnegan and the Shearwater Scuba Club for providing a bunch of photos for us to make the slides a bit more interesting. Special thanks to Coastal Health, who did originally send us some of those photos of their chamber many years ago. I don't even remember who sent them to me now, unfortunately, but it was someone over there. A special thanks to the Koh Tao Rescue and the SSS Recompression Chamber Network in Thailand, and Sonia Scott, who was kind enough to send me the Phuket and Koh Samui Recompression Chamber photos, and I believe one of the Cutest Marmarata photos as well. And that's it, folks. We're going to leave up our sort of slug slides here and to plug our next training session and see if anyone has any questions. Anna's biting her lip, which normally means there's multiple questions. Hold on.
So there's a handful of questions. I'll just start with David's comment that he just put in here. David mentions that if you call 911 in BC for a dive problem or injury, you'll immediately get, there will immediately be dispatched a helicopter or fixed wing aircraft if available.
Yeah, and I think that's I think in a previous version of this presentation, Dave, I did mention that dive emergencies are an auto launch event. I think that probably for all the folks who don't do this professionally should speak to the seriousness that dive injuries are, the seriousness or the potential that dive injuries have to decompensate rapidly. Even the people that look fine 25 minutes out of the water, half an hour out of the water, they look fine. They're walking, they're talking, and they can still deteriorate very quickly, very, very quickly after that. It is worth noting when they're being transported, when dive injuries are being transported, there are altitude ceilings on the aircraft. So because we don't want to take that patient and put them in an even lower pressure environment prior to repressurizing them, the fixed wing and the rotorcraft resources do have ceilings. You'd have to ask one of the pilots what they are, probably a couple thousand feet or something, that they will not exceed to make sure that we don't under pressurize our patient while they're going to hospital.
Andrew Finnegan says 5,000 feet.
Is that 5,000 for military, Andrew? Silence.
No, he says no.
Yeah, I mean, I know my own standard, certainly within my own training was 1,500 to 2,500 was sort of a reasonable ballpark. That might have changed, and it might be agency specific. I wouldn't want to speak on behalf of anyone's agency, either BCHS or the military or anyone else, in terms of what that is now. 5,000 doesn't seem unreasonable either. So.
He says 13 PSI maximum. Sure. Not less than. Okay, we'll start off with some of the earlier questions. Mm-hmm. Is nitrogen more soluble in adipose tissue than in the bloodstream? Does that make people with higher amounts of adipose tissue more protected from decompression illness in other areas?
Oh, that's a great question. So you're asking if people who have higher body fat will have all that nitrogen come out in their fat instead of their blood. I don't think so, because you're going to be tissue loaded. You're going to be dissolving more overall nitrogen in both the fatty tissue and the blood. So I don't think so. I don't have any literature to suggest one way or the other. Certainly people with higher body fat content are, broadly speaking, more likely to experience decompression illness than others. Again, I don't have a source for that. That's just one of those things that was taught to me many years ago and is stuck in my head. But yeah, no, it's a good question, but I don't think so. Sorry, your beer gut is not going to protect you.
Richard asks, can a diver get nitrogen narcosis on a trimix with a high helium percentage?
Depends on how deep you go. So nitrogen narcosis is a function of the partial pressure of the nitrogen. So if you're breathing a 10% helium, what's a good gas mixture example? If you're breathing something with a bunch of helium in it that still has some nitrogen in it, which most trimix mixtures have because they're a mixture of helium, nitrogen, oxygen. In theory, if you go deep enough and your oxygen mix is low enough so you're not actually becoming hyperoxic, if you can still force your ppN2 high enough and balance your other gas mixtures, I don't see why you would not still become impaired by nitrogen narcosis. It would depend on what the gas mixture actually was. Having said that, yeah, I mean, part of the reason that you breathe trimix and use alternate gas mixtures is to try and avoid the effects of narcosis. So you'd normally plan your dive to try and limit your ppN2 and limit your ppO2, and also balance that with how much helium you want on board, because helium absorbs and dissolves and comes out of solution faster. So there's a whole bunch of factors that go into that. But you would try to design your gas mixture to not experience the effects of narcosis if possible.
Cool. Sheena has just raised her hand, so I will unmute you, Sheena, in case you had a question. So if I click, there we go.
Sorry, by accident.
Oh, okay, no worries. I will mute you again.
Always causing problems, that one. Here and just plug our social media really fast. Lana gets the next question ready. For those of you guys that haven't followed us on Facebook, Instagram, or Twitter, SJA Vic BC on all of those platforms. And you can also find us on YouTube at SJA Vic BC. Just search for SJA Vic BC on YouTube and you'll find our channel as well. So, and Anna sends out that link with the emails every week. But, next question.
Okay, Chris asks, can a diver breathing a high concentration of oxygen mix suffer oxygen intoxication or toxicity similar to that of a pilot who is on 100% oxygen when descending too rapidly?
I'm not familiar with what the physiological effects of pilot oxygen toxicity are. I'm not familiar with that process at all. In fact, I've never heard of it, to be honest. You know, the effects of oxygen toxicity in a hyperbaric environment are directly related to the high ppO2 of the oxygen. So what happens is when you get up to oxygen partial pressures in excess of 1.6, 1.8, 2.0, right? So say you're breathing 100% oxygen at 2 atmospheres of pressure. The current thinking, as best I understand it, is that we actually increase the presence by forcing so much oxygen into your tissue, into your nervous system, into your bloodstream. We increase the presence of oxygen-free radicals that interact with your neurological system in an unfavorable way and trigger seizures. My understanding is, and please don't hold me to any of this, or to this part at least, my understanding is that it relates to oxygen-free radicals in the synaptic cleft. But again, I need to do a lot more research to be able to actually speak to that with any degree of authority or further knowledge. I can't imagine how, like, a pilot who's breathing oxygen is by definition not going to be in a hyperbaric environment. They're going to be in a normobaric or hypobaric environment. So I don't see how they'd be breathing oxygen, you know, at ppO2 higher than 1. So I don't see how that would be the same process. But again, I'm not familiar with pilot or an airborne oxygen system, so I can't answer that with any great detail.
Okay. There is, as I filter through the questions, there was a question asking, and it was directed towards the PCPs, ACPs, RNs, docs. The question was, how much of this do you actually learn in school? And I know when I was in PCP school a number of years ago, I will say that it was not much, couple hours, group projects, and so on. For those of you who do work for BC Ambulance, if you go into our handbook app, there's actually a fabulous section on all of this that covers the treatments, the questions you need to ask. Nick, I don't know if you had a different experience going through school, or if there's any docs or higher level practitioners that could speak to their experiences of learning about this.
So when I went through the PCP program, the version 1.0 of the presentation you guys just received was the entirety of the education the rest of my class received on dive injuries. I was just asked to teach it one afternoon, and I received no further education above what I sort of was able to contribute. You know, in terms of the ACPs and RNs and docs, I believe that there's got to be some degree of extended learning for the physicians in particular, but what it looks like, I have no idea.
Yeah, I believe this section in the BC Ambulance Handbook app is searchable to the general public. So if you search in your app store, BCEHS Handbook app, there's a whole section on dive injuries. So should you ever come across a patient with this, you can pull that up, and all those questions and treatments are right in your hand if you need them. And then I think this last question you ended up covering, and it was, how long does the person stay in the chamber? I think that was the graphs you showed there kind of covered that.
Yeah, it really does depend on how well someone responds to treatment. Yeah, it really depends on how well someone responds to treatment. I mean, someone who's got a minor dive injury might just go in for one table 6 treatment, or even less potentially. Some with significant or severe dive injuries might have to undergo many treatments over several days. Of course, the ability to maintain hemodynamic stability of a patient in a recompression chamber might also change that. So you might have to treat someone, take them out to try and stabilize them, back in. There's a lot of variables that go into that, but anywhere from a few hours to a long time.
Okay, those are all the questions that I saw come up. If anybody has anything else, please type them into the box. In the meantime, we'll talk about next week. Next week's presentation was largely organized by the St. John Ambulance Critical Incident Stress team. They have arranged for a guest speaker to join us. We will be hosting Marsha McCall. Marsha is a registered nurse and the manager of the BC Ambulance Critical Incident Stress team, although I believe she just announced her retirement, so I'm glad we're catching her. This is a pretty important topic, and one that I think we don't talk about often enough in the St. John context. So I highly recommend all of you to tune in, share with your divisions, share with your co-volunteers, and join us for next week's session. Kyra, your question, I will send you the contact. Yes, there is a contact for the SJS Critical Incident Stress team. We will be sharing that, of course. And I hope to send out the invitation to you guys in the next day or two. Yeah, that's about it for me. Nick, anything else you want to add?
Over my camera, we have a guest speaker who just wants to say hi to the group really fast. You go.
That is the unofficial Div 176 therapy dog.
Yeah, she is not nearly well enough behaved to be a therapy dog. She just kind of hangs out and mooches and gets pets and love. Okay, girl, come on. Oh.
All right, so we'll stick around for a few more minutes if anyone has questions or needs clarification on anything. Feel free to type it in the box or unmute yourself. Otherwise, send an email to my address, which Nick had on the screen just a little while ago, which I'm sure he can pop up again. And we hope you guys can join us next Monday, June 22nd, for the next talk.
Fantastic. Thanks very much, Anna.
Adam asks, with BC's, I guess this is a question for me, with BC slowly opening again, will we be meeting again in the coming months? We are slowly getting things together to be able to do that. The divisions, or the branches, I should say, the public facing side is slowly reopening. They just want to make sure that all the safety measures and PPE and everything is in place before we do that, but we are slowly moving in that direction. All right, and as everybody is exiting quickly, we'll end it there. I hope everyone has a good rest of your evening and a good week, and tune in next Monday at 7 o'clock and watch for the next invitation.